Good afternoon and welcome to the Maryland Women's Coalition for Healthcare Reform's webinar, The Affordable Care Act, Getting It Right in Maryland. I am your host, Sandy Kick, Health Policy Analyst with the Coalition. Today we are excited to present this webinar to our members so that they have the opportunity to learn about the Affordable Care Act, how it is being implemented in Maryland, and opportunities to get engaged. First, we will hear from our speakers and then host a Q&A session before wrapping up today's webinar. Please note, we have muted all phones during the presentation portion of the webinar, but we'll provide you with instructions for asking questions when we get to the Q&A portion of the webinar. Now, I'd like to introduce Lenny Preston, Chair of the Women's Coalition, who will be our moderator and one of our speakers today. Lenny?
Thank you, Sandy, and thanks to everyone that has joined the call today. I just want you to know we've done it during lunchtime because it's part of the Coalition's strategy to reduce obesity. So I hope that will be productive for all of us. The Coalition, for those of you who don't know us, is a nonpartisan alliance of thousands of individuals and now 94 statewide organizations who are all working together to ensure that every Marylander has access to high-quality, affordable, and comprehensive care, and that it is there when they need it. So we're fortunate today to have with us two other speakers, Adrienne Ellis, whom many of you know with the Mental Health Association of Maryland and director of the Maryland Parity Project, will be speaking later. And following her, Sheila McErtich, Vice President of Health Reform Initiatives at Healthcare Access Maryland, who's going to take us inside the connector entities and talk about that. So let me start just with an overview of the agenda. Many of you probably know much more than we do on the Affordable Care Act, but I'm going to set that up briefly with some context and content and talk about the specifics of what's happening in Maryland. And we'll look in some detail at the essential health benefits and the qualified health plans that will be sold at Maryland Health Connection. And we can't have Adrienne on without talking about federal parity law and how that will roll out. And then look at Maryland Health Connection and the Connector program. And no presentation by the Coalition is complete if we don't talk about ways that you can get involved. So let me start for the context. Sometimes I think people may have forgotten what the world looked like before 2010 when individuals were losing their houses, going bankrupt, and even losing their lives for lack of health care. So 45 million plus uninsured in the country and 730,000 in Maryland alone. Of those, about 10 million children and adults live with mental illness but have no insurance. 46% of adults spent part of 2012 with either no insurance or inadequate coverage. And, of course, we know that this really impacts lower-income adults who have much higher rates of un- or underinsurance. And underinsurance is a real issue. Women go without mammograms because they can't afford to pay for them, for example, while many, many struggle to pay the medical bills that they do have. So what's the answer, of course? It's the Patient Protection and Affordable Care Act, or at least that's our starting point for now. So we want to look at two pieces of this, the patient protections part, and then address the affordability piece of this. And then also, I just want to remind everybody, and we'll come back to this at the end, a high priority, I think, for all of us is that the healthcare reform initiatives can leverage of movement to the reduction of health disparities and to getting us to health equity. So just three areas to think about are non-discrimination for gender, race, ethnicity, sexual orientation, and gender identity, parity for behavioral and somatic health care, and strong preventive services that we'll get into in a minute. So let's look next at the Patient Bill of Rights. When the ACA was crafted, they recognized that it would be 3+ years before they could really get to the affordability piece of the setting up of the exchanges. And so I think very smartly they put in place to start almost right away patient bill of rights. So we all know that now young adults coming out of college don't have a job, can't get insurance. Now they can stay on their parents' health plan until the age of 26. This is one of the most popular parts of the ACA to date. Former foster youth are now Medicaid eligible up until the age of 26. Maryland has really embraced this as it has so much of the ACA. We know that seniors have already gotten help covering that donut hole, and that donut hole is going to close in a couple of years. No longer can insurance companies apply lifetime or annual limits on care, and no pre-authorization for an emergency room visit. So I like to say, well, the last time I had to race to Sibley Hospital, I didn't have to call my insurance company and make sure they were going to pay the bill. So they also can't take away our insurance without due cause, and we all love the no pre-existing condition exclusion for children, particularly two moms in Maryland who have been great spokespersons for the ACA, whose children have gotten the care they need, and they know that when they turn 18, they're going to get the health care. They won't be denied it because of a pre-existing condition. And insurers now have to spend more on our care. So in the individual market, they have to spend 80 cents of every dollar on our care, and not their care, I would say. And in the large group market, it's 85%. So that's made an enormous difference. Another big piece of the ACA is the preventive piece. How are we going to actually make advancements in health care if we don't address the preventive services first? And our full thanks go to Senator Mikulski for her Women's Health Amendment, so that now, without copays or deductibles, women get a well visit. We get breastfeeding support, so my goddaughter, now with a second child, can get a new breast pump. Family planning services, including contraception, without copays and deductibles, screenings for HIV, STI, and domestic violence, and mammograms and cervical cancer screenings. So those women who in the past couldn't afford a mammogram can now get it. And then also HPV testing, extremely important. So with that in place, then let's look at the affordability part of this, which I describe as a three-legged stool. So everybody gets in. Everybody gets access to health care. There's the personal responsibility piece, which was the Supreme Court decision on constitutionality last year. So we passed that hurdle. And what they're going to get, we hope, will be affordable. And I should stress that it will also be more comprehensive in most cases than what people can access today or afford. So to look at the affordability piece for Medicaid, that expands Medicaid up to 138% of federal poverty, or $15,282 for an individual. Part of this is that it simplifies eligibility and enrollment and correlates the calculations with that of the individual market, so it makes it all much simpler with the modified adjusted gross income calculation. Very important for everybody on the call to know is that the primary adult care enrollees are going to automatically roll over into Medicaid on January 1st of 2014. So the Medicaid office is making every effort possible, and I know many of these people on the call today are working to make sure that we can get as many people into PAC right now. The benefit package is going to remain the same, and you'll have a no wrong door for health. It won't matter where you go. You'll get your access to health care coverage. And in 2 years, with fingers crossed, we'll have a real no wrong door that will also apply to the social services. So the enrollment projections for 2014 are 108,000, so we all know there is a lot of work to be done to get there, and we're going to talk about that in a minute. So on the affordability piece, qualified health plans will be sold in the competitive marketplace known as Maryland Health Connection, and to help people afford those, they will get advanced premium tax credits for individuals from 139 to 400% of federal poverty. And let me just point out here that the Maryland Health Connection is not just for the uninsured. My hairdresser told me the other day that she was going to drop her health insurance because they'd raised the premiums. And I said, don't do that on October 1st. We're going to go to Maryland Health Connection, and I'll bet you're going to be eligible for an APTC. And, in fact, I went back and used Kaiser's calculator. And if you look at the next slide, and, in fact, for her, she's going to get an advanced tax credit of about 40% to help her pay for her insurance. So you can see the federal poverty levels, the annual income, and what the maximum premium will be as a percent of income. And we also put here the subsidy calculator link so that you can go on there and do some calculations and help others take a look at this. I know there was a question about whether the presentations will be up. We will be posting all of this after the webinar today on the Coalition's website, mdhealthcarereform.org, and it'll be on the events link, as will past webinars on cultural competency and health literacy that may be helpful for those on the call. So let me now turn it over to Adrienne Ellis with the Mental Health Association and Director of the Maryland Parity Project, and let her get into the essential health benefits a bit more.
Good afternoon, everyone, and thank you, Lenny, and the Women's Coalition for having me on the call today. I am going to talk a little bit about the qualified health plans. Lenny was talking. There we go. I apologize. I'm having some technical difficulties. I guess it's just going to be the nature of the day. So Lenny talked a little bit about the qualified health plans and the affordability piece, and that individuals are going to be able to get tax credits and help with actually purchasing the health plans. And the really great thing about the Affordable Care Act is not only does it enable people to afford health plans, but it's actually going to enable them to afford health plans that actually cover the services that are so necessary. So the Affordable Care Act is actually going to help with, as Lenny mentioned, not just the uninsured, but also the underinsured, because all of the qualified health plans that will be sold through Maryland Health Connection, both in the small group and in the individual market, have to include the essential, what the federal government calls the essential health benefits. And those include 10 categories of services that are listed here for you on the slide, some of which some plans have always covered these essential health benefits, but other plans may have been much more limited in their offering, and some of these benefit categories may have never been covered by some plans. So of note are prescription drugs. Plans will have to, all qualified health plans are going to have to cover prescription drugs. Maryland chose a small group plan as our essential health benefit benchmark plan, which has a open formulary, meaning that the majority of prescription drugs should be available. There, of course, will be cost concerns for some of the non-preferred drugs. Just like always, they're going to recommend that you choose generic drugs, and those are going to be the most affordable. But for some plans, this may be the first time that they're actually going to cover prescription drugs for all illnesses. Also of note, which is new to some insurance plans, is the habilitative and rehabilitative services. Maryland is still working to define what exactly will be covered in a habilitative services bucket, but this is really important to individuals with developmental disabilities and other areas where individuals need therapy in order to maintain a certain daily living standard. And then, of course, as important to those of us at the Mental Health Association and important to all of you should be that these plans are going to have to cover mental health and substance use disorder benefits at parity. And that's really important because not always have plans covered mental health and substance use disorder, and for those small group plans and individual plans that did cover mental health and substance use disorder, they never had to be compliant with parity until 2014. So not only will the qualified health plans provide services that people are critically in need of, but it also has some other consumer protections that are embedded within. The Maryland Insurance Administration is going to be responsible for certifying that all qualified health plans not only include the essential health benefits, but also that they have an adequate number of providers in each network to make sure that people are actually able to access the services. So it's not enough just to offer the benefit. You have to make sure that you have enough doctors on in-network so that people are actually able to get appointments and get the services which they're paying premiums for. They also, qualified health plans are also going to be required to contract with essential community providers, and those are providers we normally think of as kind of safety net providers, the federally qualified health centers, Ryan White providers where a lot of uninsured currently go to access care. It's going to be, the federal government realized that we're going to be bringing all of these new uninsured individuals into the market, and so want to be able to allow them to have some continuity of care and where they've currently been accessing care. So the plans are going to be required to have some level of essential community providers in their networks. And then in Maryland in 2015, they're also going to have to provide a continuity of care provisions, which we'll talk a little bit more about at the end of the webinar, because there's still some work to be done in this area and some things that we need to watch out for. But those continuity of care provisions are going to enable people to actually maintain continuity when they're transitioning from one plan to another plan, including between Medicaid and the qualified health plans, if that happens. And then, as I said, all qualified health plans will have to comply with the Federal Mental Health Parity Act, which is brand new and really important for anyone who has a mental illness or has a family member with a mental illness. And what is actually, as Lenny said, it wouldn't be a presentation. I couldn't do a presentation without talking about the federal parity law, but I'll try to keep it brief and talk about why it matters. The federal parity law is actually just simply trying to remove barriers for individuals to access mental health care through their health insurance, and recognizing that there had been historical discrimination in place for individuals to access this care. The law was passed to try to remove those barriers. And the law is completely based on comparability between benefits and how those benefits are managed on the medical side and the mental health and substance use disorder side. Most of you, if you've looked at those of you that are insured, if you've looked at your plan documents, you'd know that your behavioral health benefit is often managed differently than the rest of the benefits, the medical benefits. And so this law takes note of that and requires that those benefits be managed in a comparable way. They can't be any more restrictively managed on the mental health side than they are on the medical surgical side. This chart is just really kind of for your, as an FYI, it just states which plans are currently required to comply with parity. And in 2014, the small employer and the individual plans will have to comply. As of right now, they are allowed to actually not comply with parity. They've been exempt from parity up until 2014. So in 2014, pretty much all insurance plans will have to provide mental health and substance use disorder, but if they provide mental health and substance use disorder benefits, they will have to provide them at parity. The law is really complicated. Of course, there are hundreds and hundreds of pages of regulations that actually allow it to be enforced or allow the insurance commissioners and federal regulators to enforce the law. But just a couple of quick things about how it actually plays out. The law requires that if a plan offers mental health and substance use disorder in any of the 6 categories, and remember, for small group and individual plans, they have to offer mental health and substance use disorder. So if they offer it in any one of these 6 categories, then they have to offer it in all of the categories where they provide medical and surgical benefits. So no longer can plans just provide outpatient mental health care. There was a problem previously where plans didn't cover inpatient mental health care. But this law says if they cover inpatient medical care, then they have to cover inpatient mental health care. They also have to cover prescription drugs for mental health now. They also have to cover out-of-network care. So if they're providing out-of-network benefits for medical surgical care and they're providing any mental health benefit, then they have to provide out-of-network benefits for mental health care, which we know is really important because a lot of people who use mental health treatment have to go out-of-network to get it because we know there's a shortage of providers in network. The law also is really very focused on the limitations and restrictions that plans use to manage benefits. So it breaks it down into two types of limitations, the quantitative and the non-quantitative. Quantitative limitations are those limits where a plan tells you how many visits you can make or how many days of inpatient coverage you have. It's the co-payments that you have to pay or the deductibles. And the law says that any copayment or deductible or any type of quantitative limit for mental health and substance use disorder can't be more restrictive than what that same quantitative limit is for medical surgical care. So, for example, no longer can the plans charge $50 to see a psychiatrist as a copayment if they're only charging $20 to see a primary care doctor. So copayments are being brought into line, and that's currently happening now in the large market. And then the other type of limitation, and this is the one that the insurers use most frequently in terms of denying coverage, is the non-quantitative. And those are all the policies and procedures that they have in place to determine whether or not a treatment is medically necessary. So if you get a denial for your treatment and it says, we deemed you only needed 4 days of inpatient care because any more than that would not be medically necessary. The law actually says that the way they determine that medical necessity, whatever types of reviews that they use, those can't be more restrictive than what they're doing on the medical surgical side. So, for example, we know that an individual who has a stroke or a heart attack gets the inpatient care that they need in order to get well from the stroke or the heart attack. Often when someone is an inpatient for mental health care, they may just get 4 days of inpatient care without and not actually be brought back to the standard of living that they were before they were in inpatient care. So this law actually requires that any of those policies that are in place have to be comparable and can't be more restrictive. It also gets into credentialing standards, how providers are credentialed, can't be more restrictive, as well as reimbursement rates. But all of those areas are things that we're still working on figuring out how the plans can actually comply with the law in those areas. And with that, I will turn it back over to Lenny to talk us through Maryland's process.
Thank you so much, Adrienne. So with that set up, let's just look briefly at where we've come so far in Maryland. And I think we have to start out by giving thanks to Governor O'Malley, who the day after the president signed the Affordable Care Act, the governor turned around and signed an executive order setting up the Healthcare Reform Coordinating Council, whose job it was to create the roadmap that we have been on since March of 2010. And we also need to give due credit to the lieutenant governor who was charged with leading this process. And I personally won't forget last year, just before the Supreme Court decision, when he was asked what Maryland would do if the decision went against the Affordable Care Act, and he said, we will not slow down and we will not delay. And, well, we certainly have not done that. So the other really good thing that Maryland has done, or one of the other really good things that sets us apart in many ways from other states, is the stakeholder process that was put in place by the administration to, first of all, do the legislative pieces of this. So there are 3 exchange-related laws, one passed in 2011, one passed in 2012, and one passed in 2013. And they all reflect a very proactive amendment process on the part of consumer advocates, and I know many of you are on the call today and should pat yourselves on the back for what we've achieved on that front. The same stakeholder process was used with the exchange once that got up and running. So with multiple advisory committees, and again, I'm going to assume that many of you participated on that. All of this is far more robust than what we've seen in other states. And we also know that we have one of the best public health exchange boards in the country. And we're also grateful that Maryland embraced the Medicaid expansion from the very outset. As Chuck Milligan said, why would we turn down all those federal dollars? So what does all of this mean as we put it in place? And I consider it a wild ride, being one of the national leaders. And it's really like putting together a jigsaw puzzle with thousands of moving parts and often not enough rules as we wait for HHS and others to give us the regulations that we need to move forward. And sometimes we make those decisions in Maryland and then have to regroup. And all of that is done with this incredibly tight timeline. So the exchange staff deserves a lot of credit for getting us to the point at which we are today. So we are flying that airplane even as we build it, and those are happy-looking faces in that plane. I think that some of us are a little more exhausted than those look. And in part it's because not only are we providing an exchange model for Maryland, but we're really creating a national model in which the feds and other states are looking to us to see where we put the engines and how we screw on the wheels. So one of the reasons we've been able to get to this point is that the Exchange Board has decided in many cases not to make too many changes to the market as we know and love it today, but rather to collect data on issues going forward. So for those of you on the call, data collection and its use and analysis going forward will be really important. So now, what is it? Where is it that people are going to go to get those qualified health plans and determine whether they're eligible for those or Medicaid? So I just want to clarify because there's so many names running around. So Maryland Health Benefit Exchange is the official governance name for the exchange as we know it. Maryland Health Connection is the public name. That is the public face, and that's where people are going to go to determine what they are eligible for, whether it's the Medicaid expansion or the advanced premium tax credits. And there they're going to be able to make selections based upon standardized formats so they can compare premiums and copays, plan performance based on quality measures, plan ratings by quality and price. They'll be able to search for their provider, for multiple providers if they need to do that for multiple members of the family. So, and the promise of this is that you'll be able to compare these plans apples to apples. And I've said many times to many of you, if you get into that apple aisle and you can't figure out whether you want that Fuji or a Rome, there are going to be real live people there to help you. So there will be the website, marylandhealthconnection.gov. There will be a call center, the Consolidated Services Center, with individuals there to help you. We didn't put that number up, but if you've got a pencil and you want to write it down, it's 855-642-8572. That's going to have a soft rollout on August the 1st. And then there will be real live individuals in the form of navigators and assisters and certified applications and others. One thing also I would suggest, MarylandHBE.com is the stakeholder site for the exchange. You can see that on this slide. And you can go there and sign up for their weekly newsletter and stay informed. And also, of course, you can join the coalition and stay informed because we have 81 days, by my count, until October 1st when open enrollment starts. And then that will last through March 31st of 2014 for the qualified health plans, and we'll continue to have rolling enrollment for Medicaid. The full benefit plans start on January 1st, 2014. And as you know, we have both an individual exchange and we also have the small business or shop exchange. That exchange will not itself open until January 1st of 2014. And if you or you know others who want to go and get a graphic image of what Maryland Health Connection looks like, that website address is there on the slide. So who is going to be selling plans at Maryland Health Connection? So those are up on the screen here. And I would mention that at Monday's Exchange Board meeting, we learned that the multi-state plan, in other words, one that covers more than just Maryland, will be a Blue Cross Blue Shield plan. And we're also pleased that there is a co-op in Maryland, Evergreen, with a new model for care. And then, as you can see, there are a large number of companies that are going to be selling standalone dental. So getting through the maze and actually getting enrolled, outreach, and education, those are absolutely key. And the Maryland Health Benefit Exchange is rolling out its communications and outreach plans now. I think that all of us on this call need to be in constant connection with neighbors and people we come in contact with every day. My story about my hairdresser is a great example. You just never know when you're going to reach out to somebody that's going to be able to use Maryland Health Connection. And then, of course, the eligibility determination and enrollment process that's going to be facilitated with the Connector program with its navigators and assisters, and the call center. Brokers and producers will continue to have a role, and there'll be other categories as well, certified application counselors and captive producers who are going to be working for a specific insurance company. So Maryland has divided the state up into 6 regions with 6 connector entities who are the prime connection point for their specific region. And so then the next slide just gives us a regional picture of the uninsured. And again, I would just stress this will be up on the our website, so you will have access to that there. Somebody just requested the Consolidated Service Center number again, so I'm going to give that to you, but we'll also be sure that goes up on the website. So that's 855-642-8572. So now we want to turn to the navigators, those individuals who are going to be helping people from soup to nuts get through the eligibility and enrollment. There are strict training and certification requirements for them. And what I want to do now is turn this over to Sheila Mackertich. But before that, let me just stress once again, well, no, that's fine. We'll turn it over to Sheila, and that's all right. Thank you. We'll turn it over to Sheila and have her get into the connector entity scenario and provide us with sort of the behind-the-scenes picture of what that's like. Thank you, Sheila.
Thanks, Lenny, and good afternoon to everybody. It's actually a real privilege to be on a panel with my colleagues that have been working together for a few years now to try to be part of the team to get health care right in Maryland. So it's been certainly an adventure, like Lenny referenced earlier. Healthcare Access is pretty proud to be the connector for the Central Region, again, Baltimore City, Baltimore County, and Anne Arundel County. Just a little bit about Healthcare Access. We are a nonprofit agency established in 1997 by during that time, the Baltimore City Health Officer, to handle 2 major grants. One was helping people determine their eligibility for Medicaid, and the second was people who were enrolled in Medicaid but lost to care, helping identify those individuals and hopefully connecting them back up to health care. At that point, we were called Baltimore Healthcare Access, and again, around for 15 years, and over the time, it was clear that we were often getting questions about how do we apply this model in other parts of the state. So a decision was made to expand our services outside of the Baltimore City area, and we moved into Baltimore County and Anne Arundel County in the end of 2011. At the same time, we renamed ourselves Healthcare Access Maryland and established a few programs in those 2 counties. We started out modestly with those 2 core grants, $3 million in a budget, and today we have $23 million in revenue and about 19 programs. Our programs are always with a core mission of connecting people up to health insurance and helping them navigate historically the public entitlement system. Today, we get to branch that out a bit, and so those 19 programs have targeted some significant populations, or vulnerable populations, such as the homeless, people with substance abuse issues, children in foster care. Today, as a connector, we're excited to continue to reach out to those vulnerable populations and leverage that experience that we have while reaching out to really anybody who needs assistance with the new healthcare insurance landscape. Again, our areas of expertise: eligibility, enrollment, navigation of the system, care coordination, and then very big in this program, education and advocacy. We take great pride that we have a very diverse staff here. We have about 200, probably soon to be 240 people once we are fully staffed with our connector program. Very diverse and culturally competent staff, and I'll talk about that a little bit. So the central region we spoke about is those 3 jurisdictions that you see on your screen right now. When we decided to put this grant together, we were very focused on finding partners that have established experience in working with either vulnerable populations within underserved communities or with specific targeted populations. This is a very narrow window to reach people, and we felt that people had to show some real experience in doing that in the past. We found 17 partners spread throughout the jurisdictions, everybody from small community-based organizations, faith-based organizations, hospitals, people that serve very targeted, again, populations such as the homeless, those with mental illness, and also included partners that could help us. We felt it was really important. We often deal with clients that have multiple issues, including mental health issues, substance abuse issues, so we partnered with organizations like the Mental Health Association and the Coordinating Center and a group called Image to also further educate our staff and the assister and navigator staff throughout the region on again, mental health issues significant to the disability community, and to make sure that everyone is as well educated as possible as they're trying to assist people in connecting up to health insurance. This kind of gives you a quick and dirty on our formal partners. The formal partners are the ones that will receive funding from this connector grant through HCAM, but really we're working with probably 50-plus additional informal partners throughout the jurisdictions. Those partners will be organizations that ask us to deploy some of our human resources, some of our certified navigators and assisters to their organizations in order to assist people. Places where there's lots of foot traffic of the uninsured and underinsured, and people we can assist working with the partners, those informal partners that have the expertise in whatever area we're talking. In addition, places like libraries, supermarkets, we're really going to try to target the entire region in all areas to see where we can best grab the attention of potential consumers with regards to health insurance. But this really does give you a feel for the variety of formal partners that we're working with. I'll say with the formal partners, with regards to diversity and cultural competency, many of them employ multiple individuals that speak many different languages, so it'll be a great resource for us. We have many bilingual staff ourselves, mostly speaking Spanish, but a few other languages thrown in there. But it's really great to have partners that have also are very culturally sensitive and can help us really as we're trying to target the many ethnic communities throughout the 3 jurisdictions. Lenny mentioned the navigators and assisters. Those, for our region, we'll have 107. It just happens to be split down the middle, about 53 certified navigators, 53 and a half, and 53 and a half assisters. HCAM will be employing a majority of the certified navigators. Our partners are employing a majority of the assisters. Again, the big distinction between the two is the assisters can do education outreach and really help individuals that are qualified for Medicaid, deem their eligibility, enroll them, help them pick a managed care organization, while a certified navigator can do all of that, but then really help on the commercial side, help people whittle down their choices, and if they choose to enroll in a commercial product, help with that process. All of them will be doing lots of outreach and education after they receive their training, and then, our target for the 3 jurisdictions, we have about 217,000 uninsured, and so we have lots of people to try to target and go after and get enrolled in this new system. I'm not going to go over all the specifics about the differences between the two, except to say that they all require some significant training. We hope that occurs sometime in August. Again, it will be supplemented with additional training that we feel is important, and that training, again, will be aided by the Mental Health Association, a few organizations in the disability community, and as well as areas of training that we find particularly important here at HCAM. We trust that the exchange will have some robust training on cultural competency, but we'll also make sure to address that ourselves here, and just all the different facets of working with different people in the community and how best to gain trust, and that's a big thing for vulnerable populations and those that are maybe non-trusting of the government. So, how we work with clients, customers, and build that trust so that they will work with us and as they try to get enrollment into an insurance plan. So I'll just talk a little bit again about the cultural competency piece, because it really is key for our success. Lenny put up that chart that kind of broke it out a little bit in each region on the different ethnic communities that we'll be working with. But, we can tell you that regardless if it's a Latino community, one Latino community can be very different than another. Fortunately, we have great experience over the past 15 years working with a variety of ethnic communities. It takes time to do that well. An organization doesn't become culturally competent overnight. It doesn't happen after one training session. So we don't assume some of the staff that will be employed in this new project for HCAM will not be coming from HCAM. They'll be for external people that we're hiring in, so we don't expect that just sitting through training will be enough. So we're very sensitive to who we are hiring and then how they're being trained. Again, I'm sure that the training will be robust by the exchange, but we'll do a lot of follow-up training with that won't start and end in the summer of 2013. There's really no cookie-cutter approach in our efforts out in the community. If we've learned one thing, that it's one community isn't the same as another, regardless of the language. Our community advocates are very sensitive to that, and they try to really understand the communities and what the cultures are. And we are super sensitive to making sure that we are communicating to people in their language and not just translating. And there's a lot of discussion about translating materials and using language lines, and we try to be very sensitive that we are actually speaking to people directly, communicating them directly, and not just trying to translate things. It's just not effective. We will rely heavily on our peer-to-peer coaching, and mentoring, of course, is key. A lot of people will be shadowed by experienced advocates who have worked with clients out in the community, and we know it's all about relationships, as I mentioned. There has to be trust, or the bottom line is people won't enroll regardless of whether it's a commercial product or Medicaid. And the communities want to know that we're there permanently and not just dropping in. So we're not just showing up on a Monday and trying to find people and enrolling them. Our advocates work in those communities. They know the communities. They know the grocery stores. They know the laundromats. They know the media outlets. They are very familiar. We listen to our advocates. We make sure we understand what their needs are, the concerns of the community that they're serving. They regularly check in with us and tell us how we're being effective and how we're not being effective with the communication materials we're using, with the processes we're implementing. I'm very lucky to work in an organization that's been doing it for so long. And then bottom line, just constantly taking the pulse. The landscape's always changing. As a connector, I can tell you we received the award, I guess now, 60 days ago, and the landscape's changed dramatically in 60 days. So we're always trying to make sure that we are on top of things, that we're adjusting our systems and how we're targeting populations to make sure we meet the needs of everybody in the central region. So once again, I'll thank you for the opportunity to tell you a little bit about our organization. We are in the ramp-up period. We've been making every effort to bring on that new workforce, about 40 people, and in an effort to be ready to go for training in the August-September timeframe, and then very excited about open enrollment, and look forward to working with my colleagues, and again, making every effort to get it right here in Maryland. Thank you.
Thank you so much, Sheila. As always, very informative. And let me say, just on the cultural competency piece that Sheila stressed, we did do a webinar on the 24th of June about cultural competency and health literacy that was focused on the Connector program and the entities, and Sheila spoke on that. So that can be accessed on our website, mdhealthcarereform.org. And on that cultural competency and health literacy piece, again, really this is going to be part of what drives our agenda on health equity. And as I mentioned, the opportunities to leverage that with healthcare reform. And the state already has a number of initiatives that are up and running to address the reduction of disparities that include the state health improvement process and the local health action or implementation coalitions. The health enterprise zones are up and running, the pilot projects, and then a new project, the community integrated medical home, which is in the planning stage at this point. So there really is a lot of promise with healthcare reform that we will reduce disparities. I think we have to remember, although I have some friends who think that I'm going to go back to being a normal person on January 1st, 2014, that in fact this is just the beginning of the next phase. And remember that data, that's a large part of what we're going to be looking at. And there are going to be a lot of opportunities for everyone to stay engaged if they currently are, or to get engaged going forward. So more advisory committees right now. They've just formed a new one to talk about web-based entities. The coalition worked very hard with others to get a standing committee at the exchange that would be there permanently and would focus on issues related to consumers. So that will start in March of 2014, and you'll be hearing more about that. Everyone's invited to join the board meetings, which are generally held on the second Tuesday of every month, but those are up on our website. And again, if you go to marylandhbe.com, you can sign up for the newsletters and you'll learn about those. You can stay informed, obviously, by joining the coalition. You need to hold your insurers accountable, which Adrian's going to talk about in just a moment. And we all need to advocate to ensure that the strongest consumer protections are in place. So let me now turn this over to Adrian again.
Thanks again, Lenny. As Lenny mentioned, there are plenty of ways to stay involved, and one of those things is holding your insurer accountable. And the slide says parity, enforcement, and appeals, but in reality, you have quite a bit of recourse for any type of a denial that you receive, not just for mental health, but those we just happen to have an extra law which provides more consumer protections for individuals with mental illness that we didn't have before. But any denial of an authorization or a reimbursement that you get from your insurance company is appealable to the Maryland Insurance Administration. It's appealable first just internally with your insurance company. It's simply just resubmitting the claim or writing a letter to your insurance company telling them that you think that they got the billing wrong or that your treatment should have been authorized. And then the next step is writing a letter to the Maryland Insurance Administration. A lot of people are very intimidated by filing an appeal or a complaint against their insurance company, but it's only with those appeals and complaints that we can actually hold them accountable and actually make sure that we're utilizing the consumer protections that were placed into the laws for us. Parity violations are appealable and complainable if you believe that you are facing stronger restrictions on accessing your mental health coverage or your substance use disorder coverage. Then it's absolutely worthwhile to write a letter of complaint to the insurance company and as well as to the Maryland Insurance Administration to let them know what difficulty you're having and see if in fact there is a violation of the law. And then network adequacy. If you're having difficulty getting an appointment with a specialist, an in-network specialist, you have recourse at the Maryland Insurance Administration. There are law in the books that requires that the insurance company have a network that is adequate enough to make sure that you are able to access an appointment without unreasonable delay or travel. And so if you are having to travel too long of a distance to see your psychiatrist or see your OBGYN, or if you're having to wait an unreasonable time to get an appointment, those are all things that the Maryland Insurance Administration need to know so that we can make sure that the plans are held accountable for meeting those QHP requirements. As I said, the qualified health plans have some great consumer protections embedded in them, but it's going to be up to consumers and advocates to make sure that plans actually maintain those consumer protections. And one of those is, as I was just speaking about, the network adequacy. The qualified health plans are going to have the exact same standard as the current commercial market, which is the unreasonable delay or travel at appointment time. But if we're not able to collect the data and if we're not able to actually show which problems are out there, we know that there are problems in rural areas, we know that there are problems accessing appointments with child psychiatrists, but we have to be able to actually bring that data to the exchange and to the insurance administration. So I urge you that if you're having difficulty to let us know. The Affordable Care Act specifically mentions mental health and substance use disorder providers as a network requirement. Most mental health and substance use disorder providers do not qualify under federal definitions as an essential community provider, so therefore the representatives in Congress specified it in the network adequacy requirement. But we have to, again, utilize those protections or they're meaningless. Essential community providers, as I said, the qualified health plans are going to have to contract with at least 10% of the ECPs in their geographic area. These are family planning places, federally qualified health centers. But if we aren't, we again will have to hold them accountable to making sure that they are contracting with ECPs and and also that number actually meets the needs. And then continuity of care, Maryland got out ahead of the curve a bit in this, which we are very proud of, that individuals who are going to transition between plans, we know there's going to be folks who transition who are Medicaid eligible at one point and then may get a raise or may get a better job and or may get a job and therefore are no longer eligible for Medicaid, but then become eligible for a subsidy in the exchange. And so they'll go from having a Medicaid plan to having a private insurance plan to having a qualified health plan. And so recognizing that there were going to be some difficulties in the transitions and wanting to maintain continuity of care for these folks, the legislature passed a law this past session which is going to require that in 2015 all receiving plans, so all of the plans that someone goes into transitions to, have to honor prior authorizations for certain treatments. There's a list of certain illnesses or treatments that this applies to. Mental health and substance use disorder is one of those. So if you're in medical assistance or if you're in another qualified health plan and you already have an authorization for a current course of treatment, whether it be mental health and substance use disorder or for your pregnancy or for your cancer treatment, you won't have to go through another prior authorization with your new plan. They have to honor the one that's already in place. It also, and this is what's really important, another one that's really important is it allows individuals to continue treatment with their current provider at in-network cost to them. So we know that people may transition to another plan and that the doctor that they were currently seeing may not participate with that new plan, maybe only in network with certain plans and not in network with the newest plan. And so the law is going to require that the new insurance plan not only honor the prior authorization but allow you to continue to see your current provider if you so choose for the lesser of 90 days or the current course of treatment. And it's not applicable when people are transitioning from commercial carriers into the Medicaid fee-for-service program at this time, but we are hopeful that that will change as new contracts are let out in the Medicaid program, but are applicable when they transition from Medicaid fee-for-service. So if someone is currently getting fee-for-service Medicaid, mental health or substance use disorder treatment, then when they transition, if they transition to a qualified health plan, then this protection will be in place as of 2015. And again, I urge you to help us find the stories and collect the data because the exchange has to submit a report to the General Assembly in 2017, and we want to make sure that we're actually are able to really give the real data. So if there are problems out there, we want to know so that we can go back and fight for stronger protections or fix any problems. Same thing on the network adequacy and the essential community providers. The exchange staff is going to be reporting to the board about the individual's access to care, But as advocates, our job is to make sure that we're collecting those stories so that if there are real difficulties people are having accessing certain types of care, we want to make sure we're able to carry those stories to the decision makers. So with that, I turn it back over to Lenny.
Thank you very much, Adrienne. So everybody can see that nothing stops on January 1st, 2014. So we want to now open it up for your questions. And Zenobia, do you want to explain this?
Yes, thanks, Lenny. You'll hear an automated voice that says Q&A session has started. And to enter a question into the queue, first hit *6 to unmute your phone. Then when prompted, press 1 to enter the queue. When prompted to ask your question, state your name, organization, and question. Lenny and our speakers will provide answers to your questions. We'll now begin with the Q&A session. If you have a question, you may hit *6 to unmute your phone and proceed.
Thank you, Zenobia. So just to get us started while we're waiting for people to queue up, let me ask a question about consumer assistance for special populations, which Sheila, you talked a lot about the need to reach out to vulnerable populations, and we've been talking about a list of 20-plus populations. So just a couple of examples: women of childbearing age, women between 138 and 250% of federal poverty are going to move between a qualified health plan and Medicaid if they become pregnant. Then those with behavioral health issues, the homeless, the jail reentry populations, former foster youth, immigrants, navigators, assisters, and the others are going to need specialized information. So, Sheila, do you want to address how we're going to address that?
So, again, we're lucky enough here that we've done a lot of this type of outreach work before, so we can kind of capitalize on that, meaning we have extensive relationships with the corrections department. We have extensive relationships with organizations such as Healthcare for the Homeless that have all the expertise in how best to reach out to the homeless populations. And again, even though Healthcare for the Homeless might be in Baltimore City and they have a couple satellite offices, it doesn't mean we can't extrapolate that and apply it in other areas and work with shelters and such in other jurisdictions. We here have, when I say we have the relationship with corrections, we've been working in the Baltimore City Detention Center for several years, and agree that that's a key group to catch because they lose their insurance the day they step out of the jail. And what we do today is get them connected to PAC so that the day they walk out, they have their prescription medicines, they have insurance, they have food stamps as they're walking out the door. So it's, taking advantage of opportunities when you can, and it's easy to use that opportunity as they're reentering into the community. The immigrant population is, we have an immigrant services group here at Healthcare Access, and so we've, for years, been changing our ways of how we reach out to the immigrant population and partner with organizations like Johns Hopkins and very small community-based organizations to best work with those communities. So I think the one big point I would make is every group is very unique, and the strategies to address it are very unique, and we don't claim to be the experts. We just are lucky enough to have the relationships and the ability to sit down with people who are very experienced working with these populations, those with behavioral health issues. We know who to turn to, and they turn to us and ask us to partner. So I think it's key that the connector not think that they are the end-all, be-all of getting people connected to insurance and reaching out to these vulnerable populations, that we utilize every resource possible in the community. That was what the federal law was all about, leverage existing community resources. It's not just the connector that gets the grant to do it, but to leverage what's out there today and what works well, and beef that up and make it more robust. So that's our strategy and approach. I'm not going to say it's not incredibly time-consuming and takes a lot of work, but I think we feel really confident that we're going to be very effective at that.
Thank you, Sheila. And I think that just to build on that, so for those of you who aren't in HCAM's region but in other regions, reaching out to your connector entity if you represent a special population. And I would also encourage you to let us know, Lenny, L-E-N-I, at mdchcr.org, of populations that you serve and some of the issues that you're concerned about, because we're going to continue to facilitate a dialogue with the exchange to ensure that throughout Maryland we are doing the very best we can to address these populations and everybody else as well. Zenobia, have we got questions?
Yes, we do.
Okay.
I have a question.
Go ahead.
So do I.
Can I start?
My name is Al Davis. May I ask a question?
Yes.
Yes.
Okay. My question is, I think this is wonderful in many ways, but I wonder where you're going to find the clinical providers to treat the patient that you need or that will show up at your door. And by that I mean primary care physicians, nurse practitioners, nurses, etc. Where will they come from? They're stretched to the maximum right now. So I wonder, and this will be, trust me, the bottleneck. I've been in healthcare for 30 years. This will be the bottleneck. This will be where it really is a problem. I have no doubt, and I actually know, that the population you wish to serve badly needs serving. But I don't quite understand where you think the folks are going to come from to treat the people who need treatment.
So that's a question that a lot of people have been addressing, and let me just kick it off, and then if Adrian and Sheila want to weigh in. So the coalition actually, or let me back up and say the Department of Health and Mental Hygiene and the new Health Systems Infrastructure Administration is looking at this issue and is facilitating discussions in different counties to determine provider capacity and to address strategic planning around that. That's just one initiative that's going on.
Lenny, if I may interrupt, it doesn't matter whether they're looking at it. There are not enough clinicians to go around. You know that. You must know that.
Well, I think that, Adrian can pick up on this potentially, but this is in fact why this issue of network adequacy and making sure that the insurance companies have a large enough pool to draw from. We can't create them out of whole cloth, but there are, we know there are going to be issues. I think that we all know.
Not to be contrary, but the insurance companies can't either. Insurance companies have been bad guys for a long time, but the education of medical clinicians has been skewed for also a long time.
Well, we can't solve all of the problems in one day or 1 year. I don't know. Adrian, do you have something you want to add?
I agree that we can't solve all of the problems, and that everyone recognizes that there are workforce issues, but there are a lot of initiatives going on that are like the health enterprise zones, which are going to help try to recruit primary care doctors to those areas, and because they are going to include things like loan assistance repayment programs. There's there's studies and things being done to look at the differing scope of practice and whether or not we're using people up to the full potential of their licensure and their clinical experience. I think, and as Lenny was mentioning, the Department of Health and Mental Hygiene has a primary care. I mean, there's someone there who's in charge of ramping up the workforce. And so I completely agree that there are concerns. And in the mental health field, we have serious concerns about the number of, not only primary care doctors for everyone, but psychiatrists. I mean, we know we have just a shortage across the country of psychiatrists, but trying to figure out some innovative ways like telemedicine and collaborative projects that can actually help people get some level of access. Again, nothing's going to be perfect, but the idea that we want to give people insurance so that they have an opportunity to see a doctor, I think is the first step. And then, again, collecting the data and trying to make sure that we know where are the real problems so that we can target our efforts. But no, I completely agree that everyone recognizes that it is a problem, and it's going to continue to be a problem until we can educate enough providers.
Thank you. Are there other questions?
Yes.
Go ahead. Was there another question?
There was. They're not asking, so we'll move on to the next one.
Hi, this is Michelle Holzer with the Maryland Department of Aging, and I'm with our State Health Insurance Assistance Program, the SHIP program. And our population are older Marylanders, individuals with disability, particularly those who are on Medicare. My question's a little specific, and I'm not sure if it can be answered, but we're getting a lot of mixed information on this question. And I do have a email into Rebecca Pierce at Maryland Health Connections on this. But specifically, for somebody who is on Medicare, particularly those who are under age 65, there is a Maryland law that gives them some limited access to Medigap plans as long as they act within a 6-month open enrollment period, certain Medigap plans, and they're extremely, extremely expensive. So my question is that if we have somebody who, let's say, is under age 65, on Social Security disability, waiting to get onto Medicare, those would be people that we had oftentimes referred to the MHIP program or perhaps the PEC program. We would refer them to the health exchanges, health connections, for them to get a plan. If they get a health exchanges plan, one of the gold, silver, bronze, platinum, and then they age into Medicare, the question is, can they keep the plan from the health exchanges, or must they, at that point, because they are now eligible for Medicare, must they come out of that, and then we would need to help them get a Medigap plan, which, as I said, is limited in terms of what they can choose and extremely expensive. It might be a lot more expensive than for them to stay on their health exchanges plan. So I hope you understand that particular question and that this would be a proper place to ask it.
Well, I don't know about Sheila and Adrian. I would say, we're not necessarily the experts on this, although this question did come up at a conference in Howard County in May.
Probably from my people.
I think it was. And Becca Pierce at that point didn't have an answer, although or she wasn't there, but I don't think we got a firm answer from the exchange. But I think that the short answer is that they are going to go into Medicare at that point. But Michelle and also Al, if you want to follow up with any of us afterwards, or and Michelle, if you don't get an answer from the exchange and through Becca, we might be able to suggest somebody else to get to.
Because we're getting conflicting information from CMS Central Office on that question. And
yeah, well, that's not encouraging, but so complicated. So
by the way,
I'm not surprised.
I also want to say that this presentation, I've been on, I can't tell you how many dozen of them for the last, year at least, has been one of the best ones that I've heard. So I really want to thank you for doing this. And I definitely
well, thank
want
you,
your
Michelle.
flies.
We're fortunate in Maryland because there are a lot of great people here who are doing a fabulous job at every level. So, but thank you for that. That helps us all keep going, I think. Are there other questions?
There is one more question.
My name is Chris Garcia, and I'm calling from the University of Maryland. My question is rather specific. It has to do with the open enrollment program, or the open enrollment period. Should a consumer choose a plan in November, then get more information, no life changes, but just more information, can that person change plans up until the end of the open enrollment period if they're buying on the exchange?
Sheila, do you want to take that?
Yeah, I think there's a time period from enrollment, and I don't remember the number of days. I'll jot this down, and Chris, if you can pick up my email address off the slides, you can drop me an email, and I'll drop it down. I think there is a time period of enrollment, but I don't think it's long, so I don't think it's just wide open throughout the open enrollment period, but I can follow up on that for you.
Okay, and what was your name again, please?
Sheila Macritish.
Sheila. Thank you.
Sure.
And as it stands now, and Adrienne can correct me because she was at the same meeting on Monday, so you have to enroll by the 15th of the month in order to have the benefits pick up at the start of the following month. So there is, that's not surprising that would be in there. So, so are there any other questions?
Looks like we have another one.
Okay.
Hi, this is Barbara Brookmeyer in Frederick County. Thank you for this excellent presentation. One of the other callers mentioned MHIP, and there's a few of us around the table, and we just want to see if our belief is what you also understand to be the case with MHIP. We believe it'll, in Maryland, still be in existence for a few years, but we're not really sure of the details on when that's going to be phased out and whether any new enrollees will be able to join after January 1st. So I'd appreciate hearing whether you have any solid information on that or not. Thank you.
Yeah, thanks, Barbara. Nice to hear your voice. So my understanding is that no new enrollees after the first of the year. They are not going to roll all of the MHIP enrollees into the exchange immediately for what I think would be obvious reasons for the, if I can put it this way, the health of the risk pool. So, and Adrienne and Sheila may know more, or somebody else on the call, but I think they have not come to a final decision as yet as to the time frame for rolling that population in. So they may do it in a staggered manner, but I think there's more information to come on that as there is on so much else.
This is Adrienne. That was my understanding, but that also they are looking at the current MHIP enrollees and are planning to notify those MHIP enrollees who they believe may do better in the exchange. So those enrollees who will have more affordable coverage if they're qualified for subsidies or whatever it may be, that those are going to be the first people that they transition over, but that all MHIP enrollees will be notified that they have an option to go into the exchange, but they're not just going to blanket enroll them over. But people will have a choice of whether or not they can move to the exchange because the pre-existing condition is gone as of January 1, 2014.
Thank you, Adrienne. Does that answer it, Barbara, or as best we can?
Yep, that's great. Thank you.
Good. Anything else? Anybody else hanging on the line, Zenobia?
We don't have any more questions in the queue.
Okay, so let's
Lenny,
wrap
I actually
it
see a
up
question.
then. And just want to be sure that you'll see up on the screen that we've put up a number of resources that you can use, including the Maryland Health Benefit Exchanges website if you want to go there and see the presentations from the board meetings or sign up for that newsletter. And the new MarylandHealthConnection.gov site is up. It's a placeholder. They're about to take it to the next iteration before it has a soft launch before October 1st. And then the Governor's Office of Healthcare Reform, Adrian's group, the Mental Health Association of Maryland, and the Maryland Women's Coalition for Healthcare Reform. I would encourage you, if you're not a member now, the more voices we hear from. And Adrian stressed the importance of letting us know what is happening on the ground as we get into open enrollment, so that we as advocates have the information that we need to change or adapt policies. Remember, they've taken a sort of go slow approach, so the more information and data we have in the first year and 18 months, the better our recommendations going forward will be. And then I'm sure you've probably all received the multiple emails about the new healthcare.gov site. So we also mentioned the webinars on cultural competency and health literacy. We're going to be doing 2 more webinars in that series, one in September that will focus on culturally competent providers, and then the final one will look at health literate consumers. It's not good enough to just have an insurance card if you don't know how to use it and what questions to ask. And the coalition is always happy to do presentations or to help you organize one, so let us know. And do share your stories, again, what's happening on the ground, or if there are individuals who have stories that are compelling, those make such a difference in the work that we do. So, and then the final slide gives our contact information. None of us, of course, get enough emails, so do let us know if you want to follow up on anything that you heard today, or if things arise, more information that you need. And again, I just want to thank all of you for your incredible work in making sure that Maryland gets it right in healthcare reform, and we look forward to working with all of you going forward. And if there is a webinar on a specific subject or something else that you would like to have from us in the future, please contact us and let us know. We are here to help you and to work with you any way that we can. So thank you. Have a great day. Have a great summer. Bye-bye.